My name is Juan Bergua. I'm from the Hospital San Pedro de Alcántara of Cáceres, and on behalf of PETEMA study group, I present yesterday the updated results of VEN-A-QUI clinical trial. This is phase 1-2 of the combination of triplets of quirzatinib plus venetoclax comparing two arms, low-dose cytarabine and azacitidine. This is a clinical trial for older patients than 70 years old or older than 65 years old or unfit patients. So it's for the more difficult population in order to be treated. The trial consisted in two phases. In the phase 1, we were to see the quirzatinib dose for the phase 2. And in the phase 2, we make two groups, one based in low-dose cytarabine and the other for azacitidine, and compare the complete remission of both arms and the overall survival between both arms. There are another secondary objectives in this study. In the first phases, we found that the dose of quirzatinib with low-dose cytarabine was 40 milligrams, and the dose of quirzatinib in the dose with azacitidine plus venetoclax was 60 milligrams. In the phase 2, we compared two groups of 31 and 30 patients, and we obtained a composite complete remission of 56% of the patients in azacitidine and 50% in the arm of low-dose cytarabine. Both arms were comparable in terms of ECOG, previous myelodysplasia syndrome that it was in around 50% of both arms, and previous use of hypomethylase agents. It was not worth it that there were two things significant in the study. The first one, we achieved 36% of patients with minimal residual disease negative in the arm of azacitidine, and second times we have a high toxicity in terms of early death in the arm of azacitidine. We obtained the same rates of composite complete remission with comparing azacitidine and low-dose cytarabine, and the overall survival was similar in both arms. In a post-hoc analysis, we see that patients with FLT3 ITD mutation, it was mandatory to include 12 patients, achieved a median overall survival that was not reached, better than the patients with wild-type FLT3 mutation. It was an investigation group. And the second is that the patients with no previous myelodysplasia syndrome or acute myeloid leukemia of de novo in older patients have a median overall survival that was not reached in comparison with patients with previous antecedents of myelodysplastic or myeloproliferative disease. In terms of security, this is very toxic way of chemotherapy for older patients, both increased number of neutropenia, febrile neutropenia, sepsis, and pneumonia. So we think that this triplet can be used in older patients, but reducing the dose of venetoclax and quirzatinib. And we performed two amendments in the treatment. The first one, after phase 1, was to reduce the number of days of venetoclax in the first cycle of induction to 14 days. If we, in the 14 days, perform a bone marrow aspiration, and no blasts were present in the assessment of bone marrow. And the second, that patients who had complete remission, we give to the patients only 7 days of venetoclax in the following cycles. And this is the clinical trial in older patients with the triplet. And it's important for one principal reason. We have to add a new drug to the combination of low-dose cytarabine plus venetoclax or azacitidine plus venetoclax. And the terms of toxicity of the associated drugs can be very important. And perhaps the regulatory agencies must be looking for giving the 20 days of venetoclax or the complete dose of low-dose cytarabine or the azacitidine dose. I think that in the case of triplets, we have to look for a reduced dose of venetoclax and the associated dose of the combination, because if not, the problems about toxicity and neutropenia can be very important.